So welcome everyone to the meeting, and just to remind everyone that the meeting is being recorded and available on the Council's website. Okay, and also just to mention, since the agenda was published, Councillor Michelle Hume has rejoined the panel and there is no vacancy. It's just at the time the papers were issued, a vacancy was advertised, but we don't have one. We're a full board.
I didn't actually leave. It was some sort of administrative error. So
okay, thank you. Well, it's good to still have you here, so thank you. I think if we can just move on to apologies.
Yes, Chairman, we've got apologies from Jenny Shaw, and Councillor Bill Hopkins is substituting for Councillor Jenny Shaw.
Thank you. And do we have any declarations of interest? No? Super. Okay. And public participation?
No, Chairman.
Thank you. And we have the minutes of the last meeting. I think they came out slightly later. Does anyone have anything they would like to comment on? Objections? No? Okay, so we can confirm the minutes as agreed. Thank you. Okay, so then if we move on to agenda item 5, and it's the overview of Worcestershire mental health social care services. And I think if I can hand over to Kerry. Thank you.
Good morning. I'm pleased to introduce this paper, which provides a comprehensive overview of Worcester County Council's adult mental health social care service following the formal ending of our Section 75 agreement with Hereford and Worcestershire Health and Care NHS Trust back in April 2021. This period marked a significant shift in how we deliver mental health social care, with statutory responsibilities returning to the Council. Since then, we've embarked upon a wide-ranging transformation programme to strengthen governance, improve service delivery and ensure that we meet our legal duties under both the Care Act and the Mental Health Act. The paper highlights a number of the developments that we've put into place over the last 4 years and some of the key challenges going ahead. I'd like to hope that the paper provides assurance with the Council that it's responding proactively to the challenges of the post-Section 75 landscape. We're committed to delivering an integrated and person-centred care and ensuring that mental health social care remains resilient, responsive and sustainable. I welcome your reflections and invite you to consider how we can continue to support the vital area of this work, both through policy and investment, and to ensure that Worcestershire residents receive the care that they need when they need it. Thank you.
Okay, thank you. Mark, thank you.
Thanks, Chair. I was just minded to introduce as well, which we probably could have done before Aaron spoke, but Aaron Dodd is our Head of Service for Mental Health. He's come along today. He's our expert, certainly in terms of mental health services. So just wanted to make that point to the panel.
Okay, thank you. Yeah, because I had Kerry noted as giving us an overview, and but no, that's that's fine. Okay, so I think do we want to move straight to questions? Are we happy? Yeah. Okay, and I think if I go in the order that we had, I think the first one I've got is a question from Councillor Cross.
Thank you very much for this very thorough report and really valuable work that is ongoing. And I'm fairly new to the role. I'm just keen to understand. I mean, caseloads have almost doubled since 2021. Would like to understand what's driving this growth, please, and how confident we are that our system has capacity to cope in the next 3 to 5 years. And then a subset of that is the split. So there's a bit of geographical inequality going on. So that the North saw 158% rise in cases, and it'd be interesting to hear how our resources are being shifted to ensure fairness of access and safety across the whole county. Thank you.
Thank you. It's surprising when we pulled this data together actually how large the caseloads have grown. I think there's a slight glitch within the error because obviously when we first came back in April 2021 the caseloads were just lifted and shifted from our teams within the NHS back to the local authority, and as we've then grown and developed the service and worked more closely with our partners within the NHS, I think that the sort of familiarity and understanding of us and what we offer has sort of become a bit of a victim of our own success in that we're seeing that rise in numbers come through. We've also got obviously the national increase within mental health demand post-COVID, and that sort of the national figures is quite high at the moment. So We are managing, we've stabilised the workforce, and we're confident at the moment that the numbers that we have within each of the teams is able to sort of manage that with a fairly manageable caseload. We try and keep mental health caseloads to a sort of smaller proportion due to the complexity within the caseload work. Forward planning, obviously we're trying to predict what the demand will look like. We seem to have sort of petered out a little bit now, and if you look at the graphs, it sort of seems to have stabilised in terms of the growing demand. So hopefully we're sort of going through that recruitment and sort of retention of the social workforce is hoping to stabilise that caseload management.
Just to add to that as well, so you'll see our permanency rates in mental health have really improved, and what that gives us is that consistency for people's support and starting to get to know the clients, which often are on caseloads for a longer period of time than other generic social work type work. So we've hit about 80%, and you'll see we're not using any agency staff either. So as demand grows or we get peaks and troughs, we will obviously draw on that resource within the budget if we need it to top up with agency staff, although we will avoid that wherever we can. I think one of the other key features of the work that Aaron and the service have done, which is absolutely excellent, we're really proud of it, is the support within the hospitals for the hospital facilitator discharge posts, because working with individuals at a much earlier point in time means that we're not then managing as much crisis work further down the line, putting that early intervention support in, and we've always wanted to be able to invest in that, and I think that is really making a difference in terms of supporting people and engaging them with other local services that can support their mental and their physical health, which then means that hopefully over the next 3 to 5 years will also, that prevention will pay off further down the line.
Okay, thank you. And I think if we can move over to Councillor Hugh, and we had a question around the geography, didn't we? And yeah.
Thank you, Chair. Yes, it's with regard to item 10 on page 2, where it describes the geographies for the North Team and the South Team, and the North Team includes Droitwich, South Team Wychavon, which also includes Droitwich. So is Droitwich split in some way, or could you explain that one?
Thank you. Yes, so when we redeveloped the teams and we came back from the NHS, we modelled the two areas on what the footprint of the NHS community mental health teams look like. So they have 6 community mental health networks. So they have one in Droitwich, one in Bromsgrove, one in Redditch, Worcester, Evesham and Pershore and Wyre Forest. And we matched what we've got in terms of resources to a similar footprint within the NHS community mental health team, so that we could try and align what we offer with the NHS teams.
Thank you. And I think, Councillor Morris, I think you brought this paper to our attention as well. You have a question, so if I could bring you in now.
Thank you, Chair, and apologies for being a little late. First of all, it's good to see you, Aaron, and the team. I want to say well done to you all for bringing the service back to county. And transforming the offer, really. I remember you telling me it was like a divorce, and so it's trying to settle down after that divorce. So I know that takes a while, so well done. I have 3 questions, Chair. I don't know if you want me to do them one by one or all together, or just do one question.
I should perhaps just do one at a time, if that's okay. Thank you.
Okay, and hopefully it's not repeating, because in front of me was a similar point to the question. Why is there an increase in demand and complexity? Except it's a national issue, but we need to understand the reasons why it's higher north to south, and what we're doing to try and prevent, if at all you can prevent, that increase.
Thank you, Councillor Morris. It's a perfect storm. I think we, particularly within Worcestershire, we saw post-COVID a turnaround of health and social care mental health services, and I think with the changing of community mental health models to the transformation post-COVID, there was a significant increase in demand on community mental health services, which obviously knocks on to the mental health social care side of things. I think there is a huge problem within the sort of retention across the mental health workforce nationally. And that has an unfortunate knock-on effect to them people experiencing mental health in the community, where they're sort of not able to access mental health services as quickly and as promptly as they otherwise would have. I think that then we see the more increase in the crisis side of things. So we're seeing the numbers within this report and the AMP report that we produce on an annual basis. You'll see that the number of people experiencing mental health crises has also rocketed over the last few years, and the number of people we're detaining locally under the Mental Health Act has also increased. So I think that kind of perfect storm has hit probably at the worst time possible. Within our services, we've obviously now got a much better aligned North and South mental health community social work team, and we've also invested heavily in the sort of preventative stuff. So we've got now the 3 dedicated inpatient social workers who are all embedded within the mental health wards, so they pick people up as soon as they come in. They work with them during that recovery phase and hopefully dovetail back out. And we're seeing some really good preventative work in terms of the numbers of people being readmitted on multiple occasions. The length of stays that they're in hospital has massively reduced. On top of that, we've also now brought in a forensic social worker, so we've now got a much better grip over those people subject to the Ministry of Justice restrictions within the community. So we're now managing that a whole lot better. But it was a perfect storm, and we're still sort of working our way through that increased demand.
Thank you, Councillor Hoyt. Yeah.
So just to follow up on that, is the change in kind of police activity to mental health added to that perfect storm?
I think it's added problems. I wouldn't necessarily say it's increased the demand on particularly social care mental health services. It has had a knock-on impact in terms of the number of police use of powers around 136. It's also had a knock-on effect in terms of the number of times we're now having to go and apply to the courts for warrants under section 1351, because the right care, right person agenda now the police won't support unless there's a clear policing role for them without a warrant. So we've seen numbers of warrants going up, which obviously has a slight knock-on in terms of the length of time it takes to get the warrant, to coordinate all the resources and all the agencies to execute a warrant. Not hugely, but probably has had a slight increase on demand, particularly within the AMP service.
Thank you. Second question is concerning, and it's been mentioned as well, which is the excellent work that the social workers do within the wards to help the whole process effectively and to alert to what's required further downstream in terms of support. Could you talk a little more about that service, please, and how that saves potential costs by front-loading it, how we save costs further down in the process? And is this a service that we could operate more widely in terms of adult social care and not just in the mental health side?
Again, thank you for the question. It's a model that we looked at last year, and what we noticed was that having gone through the Section 75 split, the social work presence within mental health services had been sort of pulled back to the local authority, and that flow of communication and that joint working was missing. So we piloted the inpatient hospital discharge social worker last April, and we ran the pilot from April to December. The pilot showed some really good outcomes in terms of reducing the length, supporting the NHS to reduce the length of stays within adult psychiatric units. What we also noticed was by having the social worker working with the person at the point of admission and working with them through that recovery, actually the outcomes and what we were commissioning in terms of ongoing care post-discharge was massively changing from supported living and more restrictive sort of long-term placements to much more support within their own home, which has obviously, in terms of a cost benefit, hugely cost savings on particularly the 117 budget. I think we, over the duration of the pilot, it was around about £940,000 reduction in the number of commissioned supported living placements we looked at. Now we've gone to a full-time model. We've got 2 social workers embedded within the working age, so the 18 to 65 inpatient wards, and that covers all Worcestershire residents, whether they're in the Worcestershire wards or whether they are in the Hereford ward. So we cover the whole trust footprint of inpatient wards. We've also now got one embedded within the over 65s for functional mental illness. So they're working with the over 65s, and we're starting to see similar outcomes from that. It's really good in terms of ensuring that we're complying with our Care Act responsibilities, ensuring that everybody on the ward gets a Care Act assessment as part of their inpatient admission. We're certainly seeing people now leaving with clear 117 aftercare plans. And the outcomes are just much better in terms of what it is that we, there was a bit of a mindset, I think, previously where people would automatically think that once they'd gone into a hospital admission, long-term care was the only option for their discharge pathway. And obviously now we'll be able to be on the wards and re-educating the sort of doctors and the nurses and the physios about the options and what else is out there to support this cohort. I think that information's now starting to filter through, and we're seeing much clearer aftercare plans and supporting people much quickly better at home rather than inpatient.
Yeah, it's a brilliant support, and you can see quite clearly how it gives the bespoke service that we may need further down, because you've got that early intelligence and early knowledge and working with the patients. I think it's trying to see if there's a way that we could utilise that in other areas of adult social care at all.
So, yeah, and just to be clear, those posts that are currently funded by the council within the hospital settings, and we are in and have been under negotiation with the ICB for a long period of time regarding some joint funding arrangements, given the outcomes of those posts absolutely provide excellent outcomes for patients that are the responsibility of both organisations, but also we absolutely know and can evidence it does save long-term costs. So in terms of looking at any expansion of that service, we would absolutely be looking to the ICB to make some decisions around some joint funding arrangements. I am right in saying that's still under discussions are underway. So, and in terms of the other hospitals, I suppose we have a similar model already within community hospital settings. So social workers are kind of linked to all of the community hospital wards to support people out of hospital when they're on that pathway. Slightly different in terms of the acute hospitals, and there has been a review of the model within acute settings and social workers. So we previously had an integrated onward care team, but actually the direction of travel in the acutes is to provide as much of that social work support and assessment outside of the acute settings, which does make prevention within the acute settings more challenging. However, we do have the Care Navigation Hub, which is about supporting that kind of any barriers and blockers to supporting people to get home quickly. As much as we can, so we will have social work support linked to the Care Navigation Hub, but actually not on wards in acute hospitals, but we absolutely mirror that within community hospital settings.
Thank you. I think Councillor, one more question. Third question, yeah, that's cool.
I have thought of a fourth one, but you can come back to me later or not.
I think I will, but if you could do the third. Yeah.
Third one is about supply side, because obviously with such a service that requires such dedicated and specialised help in terms of the individuals we're supporting, some of that has to be out of area, and that adds to cost. Is there anything we could do to look at trying to develop more in-county supply to try and reduce costs in terms and service and help the service for individuals?
Yes, thank you, Councillor. It is something we've worked on, and it's something myself and the commissioning team in Worcester County Council have recognised was a bit of a deficit when we came back in April 2021, because commissioning for mental health community support services was previously part of the Section 75 agreement. So there'd been probably a lack of focus on commissioning of appropriate community support services. We're doing a piece of work at the moment, and have been doing it sort of for the last couple of years now with commissioning, to look at where the gaps are locally. We know that there are some gaping obvious gaps within provision, particularly around sort of 18 to 35 complex emotional type support services where people are quite high risk of deliberate self-harm and suicidal ideation. We know that the community offer at the moment isn't particularly geared up for supporting that cohort. So we're doing a piece of work at the moment to sort of go out to the providers to look at developing a bespoke type of supported living providers that could manage that level of complexity within a sort of localised supported living programme. Similarly, with males, we're looking at sort of those stepping down from forensic services who are maybe been detained under Part 3 of the Mental Health Act, where there's quite significant risks. We know locally we don't have a lot within the market to manage that level of risk and complexity. So we're again doing a piece of work with providers to look at how we can develop something localised to support that, and thus reduce the need for us to look at more expensive out-of-county placements. But yeah, it's a huge piece of work. We do a sort of annualised, we do a stock take with commissioners of what we've got, what we need, and where we can develop work with the providers to try and bring into those gaps something that will meet those needs.
That's brilliant to hear. But is there more we can do with community support in terms of finding solutions here? Because it's got to be very specialised and very appropriate, hasn't it, to the individuals? So how do we get community groups to try and support in that way?
I think it's taking a range of services that we need to look at. So right the way through from the third sector and voluntary care services that are focused on supporting people within mental health. At the moment, there are a few out there within Worcestershire, but they're all quite niche areas. Moving on then, so we can look at the domiciliary care market. You know, we know that for my cohort of people that we commission services for, a lot of the domiciliary care providers aren't experienced of working with 18 to 65 people, year-old people with complex mental health needs. They're very much in the market of supporting the over 65s with the day-to-day tasks of daily living and personal care, and that rather than working with complex mental health needs who need probably a different type of support within their own home, but still falls within that. So we've offered some training to the domiciliary care providers, and we're rolling bits and pieces of training out to them. We're also in the market now, we're trying to develop with some agencies that are more specialised, and there's a number of agencies we now have contracts with that are much more focused on working with this cohort rather than the over 65s. I said we've done the work with the supported living providers, and then the other piece of work at the moment is more probably sits within the NHS, but at the moment they're looking at redesigning their level 2 rehabs, which is like the long-term rehabilitation type model, and they're looking at a new footprint for that within Worcestershire. So overall, we're going in the right direction. There's still a bit of work to be done, but we clearly know that there are some gaps within the community services for people with mental health.
Thank you. And Councillor Ping, I think you had a question around going back to staff and target numbers of staff.
Yeah, my question was about the approved mental health professionals. And obviously we've seen a growth in caseloads since 2021. That's when we started doing it, wasn't it? And I know we've only got the data from 2022 here, but we've got a planned number of full-time staff as 9 all the way from 2022. How do we decide how many full-time staff we need? And if we're having more caseloads, shouldn't we aim to have more full-time members of staff? I know we have an issue with actually recruiting those members of staff, but it's our target, our goal for those, how many we need.
Yeah, thank you. So the approved mental health professionals team is a round-the-clock, 24-hour a day, 7 days a week, 365 days of the year service. We have, in addition to the 9 full-time who are dedicated members of staff to that service who work on a rotorised round-the-clock basis, we also have a pool of what we call spoke amps. So those are additional amps who are trained as approved mental health professionals, but are sort of spread out amongst the community teams. So we have a number that we can pull in at any one point if demand is increased, and they will work a sort of 9 to 5 rota, and we use that to bolster. Numbers-wise, yes, the number of mental health assessments is steadily growing and has done year on year, certainly for the last 3 or 4 years. We average at around about 3.8 assessments a day over the course of the year. We have on most days at least 4 amps on duty, so we've got, I'm confident we've got roughly the right numbers. It's thin, and it is thin margins, and when we look at sort of annual leave or any sickness, it kind of does tip us into a little bit of a problem in terms of coverage. But, you know, for the last 4 years, we've managed to ensure that the local authority statutory duties under Section 13 of the Mental Health Act have had a member of staff on duty 24 hours a day, and there's been no gaps.
Okay, thank you.
Yeah, thank you. That's great. And I think we've done a fantastic job of actually improving the number we have available at any time. So I'd be really pleased with that.
Thank you. I think, Councillor Huey had a question around recruitment.
Mark and Kerry want to come back.
Sorry, Mark, and did you want to come back? Sorry, I missed you. That was...
Thanks, Chair. It was just, I guess, to make the point that not just in terms of the approved mental health professionals team, but our wider social work teams as well. It's a real balancing act. We know the position that the council is in financially in that sense. And so, you know, we are often challenged as well in relation to making sure we strike that right balance between absolutely delivering our statutory responsibilities with the staff group that we've got, but we've not seen an endless increase in workforce, you know, for some time in that sense. So I guess it was just to put that in context as well, really, in terms of the you know, the ongoing challenges we face as well.
Thank you.
Thank you, Chair. Yes, it is commendable, really, very much so, that you've managed to retain the full-time equivalents that you've got. My question is really sort of thinking ahead, because I've read in the report, you know, the sort of likelihood of retiring professionals over the next few years, and whether recruitment, because you're competing with the NHS and their AFC rates, you could think outside the box to make it a more attractive role. You know, I know that Amazon, for example, have started to recruit on the basis of giving people more annual leave, not necessarily paid annual leave, but that will perhaps suit people, particularly in this pressured sort of role, if they can have a bit of more sort of downtime to balance their work life. So yeah, it was just you know, an idea maybe worth considering for future recruitment that wouldn't necessarily cost anything, but may just tip the balance in the favour of, you know, our recruitment against the NHS's recruitment.
Yes, it is a challenge, and it is, particularly with the approved mental health professionals, it is a very small national workforce. I think the last count there was about 3,800 nationally. So it's a small pool, it's an ageing workforce. I think that there's certainly a large, significant proportion of the AMPs nationally are sort of 55 and above. Locally, what we do is we've got a programme of a sort of throughput. So each year we train new AMPs. So this month, we've got 3 about to start their course, and they will hopefully then by January come on placement. They finish the course around next August, and they will then be approved and sort of come into that pool of additional resources that we've got. We've been running that quite successfully now for the last 4 years, and we've probably trained up at least 10 new AMPs. So on top of that 9 dedicated full-time AMPs who sit within the hub, both myself and the manager for the AMP service are both trained AMPs as well. So we then can drop into the rota as well, that's needed. I was out last week on an assessment myself. And then we've got this additional pool of sort of regenerative, newly qualified AMPs coming through, that when we do get vacancies within the AMP service, and what we tend to find is that those that sit within the spoke sort of part of the service will then come into the dedicated full-time as a sort of career development role. So it's a challenge, but it is working.
That's good to hear. So there isn't really the pressure on recruitment that some of the wording in the report is implying, would you say?
I think recruiting permanent dedicated AMPs is quite challenging, and we've been running sort of round-the-clock job adverts now for around about a year, but we're seeing that across mental health social work. Yes, we can get newly qualified and those sort of coming through on their ASYE programme fairly easily, and we've had to really invest in that grow your own model over the last 4 years to bring the workforce up. Finding experienced is where the challenge really lies, and we're seeing that across both mental health social work and within the approved mental health services, because it's a job seekers market and there's not that many of us out there.
Just to add to that as well, there's a piece of work that we've signed up regionally too, in terms of agency AMPs. So what we saw through COVID and beyond were a number of organisations using agency AMPs with rapidly growing hourly rates, so competing against each other across the region with some quite eye-watering costs attached to them. So regionally, we've signed up to an MOU to cap agency rates, and the social work roles, the AMP roles, are all within that. So what we hope to achieve there also is the cohort that choose to work via agencies may reconsider long-term positions within councils, and therefore hopefully get some of the permanency rates up. I mean, you can see from the report our current permanency rates, I would say, are probably one of the best in the region from speaking to the West Midlands employers who are leading on the piece of work with us around the MOU. So they certainly have asked to use our model as an example. And when you talk about, you know, what the reward is and how we keep people, I mean, obviously we have to work within the council's T's and C's and can't have cohorts of staff with different offers, I suppose, necessarily. But we do look at market force supplements when we have to, and we will review those regularly across the service to see whether, you know, the attraction for us here in Worcestershire pay-wise is where it needs to be, but also how our model looks in terms of, you know, the type of organisation people want to work for and the culture of that organisation. That's why our AMP service is as fantastic as it is, and we're retaining those staff. The issue around experienced AMPs and experienced social workers across the board is the national issue, and it is the key issue. So we absolutely do fantastically well here in Worcestershire investing in, you know, the newly qualified social workers. Then the key for us, like you say, is retaining those for a number of years within the service until they become our experienced social workers and experienced AMPs. But, you know, the model we've got at the moment, I genuinely think is as good as we're going to get it, and probably one of the best within the region. The team really have done a fantastic job.
Thank you. And I think, Councillor Cross, you had a question around this as well. Yeah.
Thank you. Yes, Chair. I have two questions on this report. The first one was, I'll take them just one at a time though, about the mental health care provider market. Really encouraging. So I had a question lined up about the analysis and development work that we're doing, and that was answered, and, you know, largely, and thank you very much, you know, and it's given a lot of reassurance. Regarding work with third sector and voluntary organisations, are we connected with Worcester Food Bank, St Paul's Hospice and MAGS, for example, in Worcester?
Yeah, we work really closely with St Paul's and MAGS Day Centre. We do a lot of joint working, and particularly within the mental health services, we have quite close working relationships. Food banks we're building up on, and we, both North and South mental health social work teams, have got links in with pretty much all the regional food banks and third sector stuff. In fact, I think they were looking at expanding that, and we keep a sort of database within the teams of all the different types of services and what's out there for different cohorts, sort of veterans and sort of other sort of specific niche areas. So we've got a fairly good community capacity sort of mapped out network within the team. Always welcome to hear new voluntary sector things that are opening up, and we add them to our list as and when we come across them.
Thank you. Yes, because there are changes in, you know, Worcester City Council's community engagement is massively changed, and, you know, it was very impressive hearing about how much support that, for example, the food bank give. It's not just about, you know, sit down and receive a parcel of food, but actually tell us your story and signposting. So together with our changes about community services directory, some, you know, really good hand-in-hand work can be done together. So happy to help with that whichever way I can. So please email me. Thank you.
Thank you.
Thank you. I think, Councillor Cross, did you have a second question? Or?
Thank you. Yes, if you have to take that now. So I wanted to hear about the forensic social worker role. If we have any stats yet, please. I mean, great to hear this. Have we got any? Is it a bit too early to ask about stats? If we've got anything showing how cost effective this is in terms of preventing delayed discharges or managing risks within forensic mental health? Thank you.
Thank you. Yes, I do have data, not with me. Unfortunately, I wasn't anticipating questions around the forensic social work role and the stats around that. What we recognised is when we came back was there were a cohort of those who live within Worcestershire community with quite complex and severe and enduring mental ill health who are also subject to restrictions within the Ministry of Justice. Previously, that had sort of been coordinated by the local mental health trust, and what we wanted to do is actually be assured ourselves of the right numbers, that we knew who was and wasn't on those registers, and to make sure that where we as a local authority have a duty to sort of undertake the social supervisor role, that we had a database of those. So we've now got a spreadsheet with all those under restrictions, under which organisation they are, those who are currently within some of our more secure forensic services who are due to be stepped down back into the community. So our forensic social worker will liaise with the hospitals and the low secure units to coordinate that step down, and hopefully we've only got the one, and she sort of coordinates a sort of overall governance around who we are and aren't working with, but also offers much more support and sort of peer supervision then to other staff within the council who offer that role of a social supervisor.
Thank you. Really, again, really encouraging. Spot on. So happy to receive information. Just keen to be clued up on this. Back to Worcester City Council, City, for example, the community safety team, again, changes and cuts, and sometimes the way that we councillors become aware of people with complex needs is regular messaging, people contact us and we're struggling to help as to how we're aware of a need but unsure how best to help. So if all members could be provided with information about how to highlight, how best to respond. Thank you very much. Really encouraging to hear more as well, especially also with, if you need to link up with the community safety team in Worcester, happy to help there as well.
I may take you up on that, thank you.
Of course, thank you. I think, Councillor Edmonds, I think you had some comments around, the private and the voluntary sector based on it. Yeah, thank you.
Thank you, Chair. Dave Edmonds. I represent Redditch Central. In my travels, I've gone around and seen a couple of voluntary organisations who expressed the desire to work more closely with you. One of the recurring themes that you've talked about so far is staff. Experienced staff retention, growing it. Well, these people seem to have a pool of people that are available to you, and I'd like to commit really whether you would work with these teams. You may be already, it's just my ignorance of the matter. But there are a number there. I think one is Sandyland in Redditch. No, so perhaps we could go offline and talk about that at some point, because there is a real desire. They're filling a need at the moment. They've been there some time. So given what you've said so far, I think there might be a good hookup there. Okay, thank you very much. And I do appreciate the work you're doing. I'm absolutely bowled over with this report. It's very deep if you're not involved in this sector, but I can see the efforts that's been made. Thank you.
Yeah, thank you. I mean, hopefully the report that's here today in front of you is phase one of that rebuilding of a service from the point of which we came back to the local authority, setting those services up. Hopefully going forward, certainly the sort of second phase of the whole service transformation will be much more around that community capacity and understanding and mapping out what is and isn't there. Much more focus on preventative work, and much more, if we pull in the sort of themes of the Care Act around prevent, reduce, delay. Hopefully, if we can start to build a much broader net map of what is out there in the voluntary sector, that then will sort of help with that preventative work. Because for me, it's, prevention is much more better than a cure.
Thank you very much.
Thank you. And I think, Councillor Morris, did you have a fourth question?
Thank you, Chair. It's probably one we can't answer, but as I remember, Aaron, you talking to me about the divorce and bringing the service back to county. How does that now look with LGR, local government review and the future, will the divorce be a remarry?
Thanks, Councillor Morris. I don't anticipate, us or going back to a position where we had a much more devolved relationship with social care staff sat out in the Hereford and Worcestershire Health and Care Trust at the time. The rationale, although I wasn't around at the time, but did exactly the same thing in another local authority, for bringing the workforce back in, is so that we could absolutely assure ourselves as a local authority that we were meeting our Care Act responsibilities. And I don't see that, I wouldn't see that necessarily changing. We still obviously have a close working relationship with the, if I can put it, clinical side of mental health services, but I wouldn't anticipate that LGR would move us in a different direction in relation to the direct responsibility that we now have for those staff. As the Director of Adult Social Services, it's a fundamental need for me to assure ourselves that we are meeting our Care Act responsibilities.
Thank you.
So just say it's good to hear that, because I can see the great work that's been done and how that's added to improvements for the whole area.
Thank you. And I think, do we have any further questions? I think we're covered. Okay, thank you. And I think obviously as a scrutiny board for each item, we're here to consider and comment on the information, which we have done and questioned, and also to agree any comments to highlight to the Cabinet member. But I think, I'm assuming we've covered all we need. And also it talks about whether there's any further information or scrutiny on a particular topic is required. But I think I'll let Mark speak. Yeah, go on.
Sorry, Chair. It was just really to say, and obviously I know these reports come before the committee to ensure that we are scrutinising adults in terms of, assurance to the council that we're doing everything we can to meet our statutory obligations. I just wanted to go on record, if I could, Chair, in that sense, in terms of a question that was asked by Councillor Hume in terms of what more could we do in terms of retaining staff and retaining good quality staff from that point of view. One of my responses in relation to that is the fantastic leadership that we see in Aaron today in terms of the report that is produced, and having that good, strong leadership within a service really does mean that you get a good commitment from your staff group then. And that real understanding about the service and what we are trying to do for very vulnerable people in Worcestershire. So I just want to make that point and commend Aaron's report and his work that he does every day of the week.
Well, thank you. And I think it's been really good to have this opportunity now to see how, since the service has been brought back in-house, how we've managed and what we have achieved. So thank you to all officers, and thank you to Councillor Morris for bringing this to our attention. And so I think we don't have any further scrutiny on that topic. So if we move on to agenda item 6, and it's an update on NHS continuing healthcare, I think Kerry McCrossan is going to give us a bit of an overview. Thank you.
Yes, thank you. So I'm Kerry McCrossan, Assistant Director for Adult Social Care. I've also got with me today Francesca Darby, who's our Head of Service for Learning Disabilities, Continuing Healthcare, and our Adult Neurodiversity team. So Francesca has a significant role to play in terms of the partnership arrangements with the ICB, Continuing Healthcare, and kind of the governance and policies and procedures and the ways of working with our health colleagues. So she'll also join into the questions, but I'll just give you a bit of an overview of the paper. Just to say, we've also got Richard here for the finance paper, but again, if there's any questions around CHC and finance, Rich is the man who's provided some of the details in the report. So assuming obviously you've read the report and you'll have some questions, I'm sure, so I'm not going to go into too many details, but just to kind of highlight it really is a complex area of partnership working with the ICB and the local authority. And key, it's really complex for residents to understand in terms of, what health funding is, what's defined as a primary health need, and that it's not diagnosis-led. We will, or if you're on the end of life pathway, it's not necessarily going to meet the criteria for fast track funding. And that's really difficult for people to understand. So one of our key roles is to support people through that process, although it is a health-led process. So we want to make sure that social needs and healthcare needs are they're captured, and that the support, the decision making, but that decision making ultimately does lie with the ICB. Then from obviously a funding and forecasting perspective, you know, it's challenging because we don't know all the people who are already funded through the ICB for continuing healthcare or fast track funding. That's data that we wouldn't know. But obviously when people are having reviews of their funding, we will be invited to join those reviews. And therefore quite often that's the first time that we will know about somebody, and therefore we need to do an assessment of their needs and consider whether we believe the evidence suggests that they should continue to be health funded, they should have joint funding, or whether they should remain fast track funded, for example. So it's just really important to kind of understand that while we're trying to kind of manage our demand-led service and the financial side of that, CHC and fast track funding, etc., can make that quite challenging. You'll see from the paper we had invested some years ago in a number of staff for continuing healthcare, and we gave them some specialist training, and that meant we could attend more of the reviews and assessment meetings for CHC. However, we've had a period of time where we've repurposed that funding to create the neurodiversity service, which we absolutely knew we needed to do and to improve the outcomes for people with that set of needs and upskill social workers. But what that has meant is that whilst the workers continue to support people through the CHC process, that it has been a challenge to attend as many of those assessments and care reviews by our generic teams that would otherwise be responsible for that cohort of people as they come through. But we're absolutely delighted to have had some additional investment again now, and we're out recruiting at the moment to some social worker and social care worker posts to bring that team back up to 6 to 7 people within the service, and hopefully that will support us to make sure that people continue to receive the funding that they should receive, that if they don't meet the eligibility for that funding, that we've got time to support and assess and ensure that, you know, bringing them into local authority of funding is a smooth transition for them. That's really important, because up until now they won't have been paying towards their care, and obviously local authority care requires financial assessments and often quite significant client contributions, or even having to sell properties, etc., to pay for care. So really, really important. And then the other key piece of work that we're doing with the ICB at the moment, particularly given they've brought in some new sort of policies and procedures, is making sure that we work together in partnership, that when someone no longer has a complex need and a clinical need that's determined to be a primary health need, that we start to right-size those packages of care rather than just adopt the local authority adopt the the as-is, which can be very, very high cost packages running into thousands of pounds per week. And we need staff expertise to do that, particularly in this area of continuing healthcare. And we really heavily rely on the council's legal team to support us, particularly when there are disputes. A lot of these we do manage locally with Hereford and Worcestershire ICB, but there's a significant number that we manage out of area when people are placed out of area, and we're working with the ICBs for that footprint. So hopefully you can see, we've achieved quite a lot of work since the last paper was brought to Scrutiny panel, and there continues to be significant amounts for us to do, but hopefully with the additional investment in some of the CHC roles, that will support Francesca to drive that forward over the next 12 months, and happy to take questions.
Thank you, Kerry. And I think, Councillor Pringley, would you like to ask your question first, bearing time? Yeah, thank you.
Thank you, Chair. I do have to go soon. My question was about, and firstly, thank you for the reports, both reports, fantastic. It was about legal implications, which I think was on page 27. Let me just say it to tell you exactly what it says. It says, under the Care Duty Act, local authorities have a duty to meet assessed eligible needs. The duty arises when the adult is ordinarily resident in the authority's area. And I just had a quick question about if an adult doesn't have a fixed address, say if they're from a traveller community or if they are currently homeless, how does our duty of care work? Do we still have essentially care over that person, or who does?
The Care Act is really clear that we should not be disadvantaging people or delaying care and support for somebody that meets the criteria of the Care Act through disputes with other local authorities, for example, or where people have no fixed abode, that we should continue to provide an assessment, and if there is a need for care and support, that we provide that, and then we would work with the individuals and other local authority areas to work out who is responsible after the local authority where the person is currently residing is. So we would, if somebody is homeless, no fixed abode, or as you say, from the travelling community and they're in Worcestershire and they do require an assessment, we would absolutely provide that under the Care Act in terms of the council. When it comes to continuing healthcare, that would be a discussion between the ICB and a neighbouring ICB in terms of who's responsible. But my understanding of their duties is they're very similar to that of the local authorities. So you would provide the service and then you would consider the ordinary residency after that, should there be evidence that suggests that that individual is the responsibility of a different area.
Thank you, that's great to know.
Thank you. Thank you. And I think Councillor Hardman had a question around, I think when we look at the decision support tools and that they've moved the notice from, is it 28 days to 14? Yeah. Councillor Hardman, sorry, I think you need to put your microphone on.
The period from 28 to 14, because then we would be picking up, I take it, an extra 2 weeks of cost if the decision went against us. And I just felt that we often seem to get into these slightly odd disputes with them. And whether it's a lack of communication on their side or us not understanding their position, I find it quite odd. But at a time when they're obviously aware that we're under great pressure, they are trying to move costs onto us.
Yeah, there is probably, Councillor Hardman's maybe something behind some of that. I guess just on the whole issue really in terms of continuing healthcare, I've just actually received a report at the back end of last week from the Nuffield Trust that have done a report in relation to the future of continuing healthcare and the current issues that we probably have in the system. As Kerry alluded to, a very complex area. Yes, we have a framework, but that framework for continued healthcare doesn't always describe, the finer detail that really is thrashed out locally then in terms of whether it's 28 days, whether it's 14 days. So we can't necessarily just point to the framework all the time to resolve the issues that we have. And we are still in discussions with our ICB colleagues in terms of that change that we have seen here more locally. However, there are other, I think maybe your comment, Councillor Hardman, was in relation to other funding though that we do receive from the ICB in some areas, which actually they may feel they don't necessarily have to provide us with that funding. So there's often that debate and tension around the various funding streams. I think the important thing for continuing healthcare, though, is the impact on individual as well. As Kerry alluded to, if you are eligible for continuing healthcare, you will not contribute towards your care financially. But as you've heard, if you are eligible for adult social care in that sense, there will be a financial assessment, and most people, unless it is a nil charge, which sometimes we have, but will contribute financially to the care that they receive.
Thank you. Councillor Morris.
It's on a similar vein. I've got two questions, but I'll double load it into one. So if we are 14 days notice, are our NHS colleagues still pulling the plug and as being the default option to continue in healthcare? And what cost is that adding to the council because the NHS are pulling funding? And secondly, do we have a legal representative now in the legal team for adult social care? Or do we have two, which we should have?
In terms of the legal support, yes, we absolutely do have legal support, excellent legal support within the council. There has been some changes, but we absolutely do get the support when we require it. I think we just can't underestimate how long that process takes when we've reached a point where we require legal support, and that's usually because the ICB in question, whichever ICB that is, isn't being responsive to follow the levels within the framework in terms of disputing cases. Where we follow the levels and we've got engagement with the local authority, then obviously the dispute levels are set out within the framework, and certainly within Hereford and Worcestershire, we follow those. And if we still can't reach an agreement, fairly recently we've had independent arbitration meetings, of which myself and Associate Director from the ICB will have an independent person review the case and our decision making, and we'll make that final decision whether somebody is eligible or not. So I think from a financial point of view, I mean, Rich might want to come in. It's really difficult for us at this point in time to try and identify what the impact of the 14 days is rather than 28. And it's quite difficult for us to understand the difference in the CHC income we receive, because I think I've referred to it in the paper that we've made a change where historically the council have always continue to commission the joint health part of a package of care, then we'll recharge the ICB for it, and therefore that will be counted as part of our income. However, what we've moved to is a point where we now say to the ICB, we won't do that. And they need to purchase and commission that health element separately within their own organisation. That's really important for us, and it's a shift in the right direction, because what will happen is that when we are the commissioner of all of the care and there are issues with increases in care, non-payment, fee uplifts every year, obviously that's two different processes for the ICB and the local authority, it becomes really difficult. So what we want to do is make sure, when we talked about also right sizing the package, so if the ICB decide that somebody no longer has a health need for that 20 hours a week of one-to-one care, for example, they talk to the provider and decommission their package of care, rather than we continue to pay the additional 20 hours a week, and it takes months for us to sort that out with the provider. So it's really, really difficult. We've had a drop in income. We have, you can see that on the paper, but some of that will be to do with no longer receiving the income on the joint funding packages of care.
Thank you. And I think, Councillor Cross, you had a question around this. Thank you.
Thank you. Yes, I do. Again, another great report. Lots to get our teeth into. I'd really be keen to know how many continuing healthcare funding appeals are ongoing and how much council resource is being spent on managing disputes with the NHS. And sort of as a follow-on, I'd love this to be an area that is illuminated in future reports with comparative trend data, just so we can see what are we dealing with and how's the trend, how's it going, and how much is it costing us. Thank you.
I'll pass you on to Francesca in terms of how we track the cases that are currently in one of the dispute levels. But in terms of appeals, certainly we can ask our partners to provide information on that to share with you. I did ask for some additional information because we do report usually on sort of more on conversion rates and numbers of appeals and disputes, etc. But because they've just implemented a new system, the last 2 or 3 months have solely been about the implementation of the new system, and the timing of this report meant that they weren't able to provide that information. So as soon as I do receive that, I'm more than happy to pass that on. We are no longer currently under the appeals process part of that with the ICB. So their appeals process doesn't, we don't get invited to those. Historically, we used to. We used to sit on an appeals panel with an independent chair, local authority rep and an ICB rep. They have a different process now. It's still in line with the framework. And so really the first we hear of the outcome of an appeal is when we are notified. So this morning I was notified just a timely manner before I came in that actually an appeal had been won, and therefore the individual will have their funding reinstated, and therefore we will make arrangements to reimburse the individual for any local authority costs, etc. But we don't have the numbers accessible to us to be able to say how many of those are underway. Whereby disputes that the local authority have raised, we track all of those. Francesca will give you a bit more information.
Thank you. So yes, we keep a centralised record of our disputes that we have across levels 1, 2 and 3. And just in reference to your point about the amount of work that is required to obviously take part in the disputes, record the disputes, prepare for the disputes, it's a considerable lot of time for council officers to do that. So that's why we've looked at having that dedicated resource so we can support the generic teams in having those disputes, because we suspect they are going to increase, particularly with the issues that Kerry's raised in the paper.
Thank you. And Councillor Hardman. Thank you.
At the moment, we've been concentrating rather, I mean, you know, on the effect on the council. I mean, Kerry might correct me, but of course, this can have a relatively devastating effect on individuals, because you know, if you're moving it to a fortnight and they suddenly don't qualify for CQC, of course, if they have assets, then they start burning through their assets, which is why, I mean, I'm sure other members have had, you know, really quite difficult conversations with relatives over, you know, the £24,000 limit. And this often seems to come as a bit of a bolt from the blue to them. So I don't know whether we're engaging with them when you get to the review stage. I mean, I just don't know quite. But often they don't seem to be aware of the potential liability that their loved one is about to pick up. Does that make sense? Probably not.
Yeah, it absolutely makes sense. Yes, I mean, 14 days for somebody to be told that they no longer receive continuing healthcare funding, for which, you know, a number of people will have received that for many, many years. And some people much shorter periods of time if they've had fast-track funding, for example. But 3 months later, you know, they're deemed to no longer be in a rapidly deteriorating condition. And therefore, you know, from the point in which we've had the review or the DST, the assessment, people will then receive a letter saying they no longer meet the criteria, and that the referral has obviously been made to adult social care, and that comes into us. But obviously if we've already known about them and we've attended, then we've been able to start to have some of those conversations. I think kind of the wider communications is really important for residents to understand the costs of adult social care per se, whether it's, you know, whether they've had any health funding or not. And we're just about to launch a further communications called The Cost of Care, which was really successful last time we did it, which is a campaign that explains to people how adult social care funding works and the associated costs, so that we really start to support the education of the general public about what this means, so that if they are ever in this situation with continuing healthcare where that is free at the point of delivery, that they have that understanding that this is going to be a significant change for them. I mean, ultimately, they need to meet the thresholds and within the framework to continue to have funding, and that's the debate that we will have, is whether they do still meet the criteria or they don't, because it isn't, continuing healthcare isn't funding for life, it is about having a primary health need, but the areas that we find most difficult are managed need, and the framework is really clear that if needs are still needs but they're being really well managed, that people should continue to receive their funding. And quite often that's what people would say to us, but the person's still got the need. It's just that they're much more settled now because they're having really good quality care. And that's our job in social care when we are involved, to really try and evidence that, you know, is the need still the need or not. But yeah, really difficult and has some significantly life-changing decisions that need to be made quite often when people fall out of free care into local authority funding. Like you say, assets, houses, and some quite significant self-funding care costs often.
Okay, thank you. And I'll move on to Councillor Morris, but just to know how important the messaging is, because at that particular point in time, it is particularly stressful for people. And I've known with my own family circumstance, I'm a qualified accountant, but I didn't feel able to navigate the finances and the number because you're so emotionally involved. So I think the more we can do to make people aware and help them, that's really important. Thank you. Well, Councillor Morris.
Thank you, Chair. Yeah, and I've got confidence in our service. I think we've got some fantastic staff, but I know an area like continuing healthcare does bring some concerns and some issues. They're working very closely with the ICB. What I'd like to ask Kerry and Francesca, I guess, is what could we do as a scrutiny panel to help them more effectively in terms of their delivery? Is there something that we could look at or something we could scrutinise to try and support them more fully? And not to lead them, I would like us to ask the ICB to come here and to ask them about continuing healthcare and their role within it, and particularly with the 14 days.
I think just in terms of the question to the ICB, actually the Associate Director had talked about joining the panel today. We did say that, you know, we would focus on the local authority aspect of our role within continuing healthcare for this specific paper, and also ensuring there isn't a crossover between sort of the health and wellbeing board agendas and this panel. But it's absolutely something that we could arrange and invite in terms of thinking about what you could do to support the process, and we could absolutely put some thought into that. There are, you know, I think it is a challenging area, but it is important to say we do sustain good working relationships with our ICB partners, despite the difficulties that both organisations are facing with, you know, funding, you know, the financial issues, etc. And the governance, you know, Mark sits on the exec board for continuing healthcare, and Francesca sits on an operational board and meets weekly at the moment to try and unblock issues. And then I sit on a monthly partnership board. So there is quite a lot of governance around it in terms of us thinking about, you know, what could we do that would make a difference, and what could you do to support us. So we could certainly put some thought into that. I think the 14 to 28 day debate is part of a broader conversation with Mark and the ICB, thinking about it in the wider context of some of the other arrangements we have with the ICB at the moment. Thank you. And Councillor Hardman. Thanks.
I mean, that's very helpful, Mark and Kerry. I mean, the bit that does bother me is that the ICB have changed the system, and I was asked exactly this question last week, rather interestingly, because they the client who phoned me up wanted to know how he got his voice heard at the panel. And my only answer to him was, well, I think you probably want to try HealthWatch. Now, whether that was the correct pathway to point him to, but it does seem to me that we are now excluding not only ourselves, but the public, you know, the cabinet member and the director. Well, the director still sits on the ICB, but it doesn't feel open and transparent to me.
Thanks, Councillor Hardman. Just listening to your challenge in that sense, Councillor Hardman, and I think what this is set at the moment is against the backdrop nationally in terms of continuing healthcare. So we'll all know that there are going to be changes to the integrated care boards. They are going to deliver over a much wider footprint than they currently do. So as you know, before we've had Hereford and Worcestershire ICB, they're now buddying up, I think is the term that's being used, with Coventry and Warwickshire. But at the same time of that move, they are being required by the end of this financial year to reduce their operating costs by 50%. And that will be through, presumably, reductions in the staffing levels in ICBs from that point of view. Whether continual healthcare gets tied up in that conversation about the finances is still a little unclear, really, because that shouldn't necessarily be their operating costs. That's the payment for care that they're making. And also, there has been some debate about, in the longer term, whether ICBs will retain their responsibility around continuing healthcare or whether it will sit somewhere else in the system. Now, I think the report that I alluded to earlier that's just landed is firmly putting the suggestion back to the fact that ICBs will continue to have responsibility for continuing healthcare budgets, and that won't sit elsewhere in the system in the future. If it's helpful, I don't see that there should be any restrictions on the report that I've got, but if I can check that through, I'd be more than happy to share the report with Scrutiny Committee members, because it does unpick a little bit more some of the issues that we're currently facing, not just locally, but nationally in terms of continuing healthcare. I don't know if there'll be any use.
It was helpful of you to remind us that the ICB are trying to cut their administrative costs by 50%, which, of course, then very neatly, in my view, explains why we got from 28 to 14. That's a very easy thing to do. But that would be me just speculating. But I do think that if they're not careful, they'll start to get a considerable amount of legal challenge from outside bodies, possibly no-win, no-fee lawyers. I mean, I can see that rather than lowering their costs, they could well be going to drive them up, but we'll see.
So, Councillor Harvin, thank you. And I think just around, obviously, numbers and things, obviously, I think we've touched on this before, there's the sort of 60-40 funding split with us and the ICB. Yeah.
Sorry, Chair. Yeah, that relates specifically to Section 117. So, I don't, you know, it sits in Aaron's world in relation to the split that was previously agreed. And you're right, Chair, it was on a 60-40 basis for Section 117, where the council is currently picking up the 60% payment for those cases. We have a lot of work that's taking place around that area of work, including reviewing whether people are still eligible as well for Section 117 funding, as well as reviewing their care needs. So I think that's what you was alluding to in terms of that particular split. But again, we're back to, I suppose, a sense of what is our current policy or custom and practice, which is the 60-40 as it stands. But if you go back to the legislative trail on it, all it will say is that it's a joint responsibility for the NHS local and the local authority in terms of funding Section 117 aftercare. What it doesn't do is say what that split should be.
Thank you. So it's a good example of legislation not being very specific. Okay. Do we have any more questions or comments on CHC. Councillor Hardman.
Just on the 60-40 split, I mean, there are quite a lot of authorities who are on 50-50, which would be more advantageous to us. I mean, I don't know whether there's anybody higher than 60-40, 70-30, but it always just struck me that somehow this decision that was made, I'm going to have a shot at 2007. No, after that. Oh, right, 2014.
I think it would have been after that. It was when Paula Furnival was our DAS,
Ah,
so
right.
I would say it was 5 or 6
Okay.
years ago.
Yeah.
At
Okay,
best.
never seems to be particularly fair to me, but, you know, I better shut up, really, because I was obviously the cabinet member who approved it.
Thank you. Yeah, do we have any further questions or comments? No. No, so I think if we're happy to move on to the next agenda item, and thank you. So we move on to item 7, it's performance and 25-26 in-year budget monitoring. Yeah, and I think we're handing over to Katie. Thank you.
Sorry, we're just deciding whether we move to the front or we stayed here, but we'll stay here.
Stay where you are.
Okay, so hello everyone. I will talk through our position on the 5 key performance indicators for you, highlighting both achievements and areas requiring attention for our adult social care and wellbeing performance for Q1 of the 25-26 data. So the first key performance indicator is admissions to permanent care ages 18 to 64. You'll see from the report that our target rate is 13.4 for admissions per 100,000. As of June 2025, we're at 21.9, so significantly above our target and rated red. This spike is largely attributed to a surge in what we believe to be admissions between February and April, likely driven by year-end purchasing pressures and delays in legal funding processes. Despite this, we continue to prioritise alternatives and such as supported living and family-based care. We are undertaking deep dives into admissions data, including length of stay and leaver rates, to better understand and manage this trend. Controls remain in place to ensure admissions are only used when absolutely necessary. While the numbers are concerning, our commissioning panels are actively reviewing each case to ensure community-based options are maximised. The key performance for number 2 is the admissions to permanent care ages 65 plus. Here our target is 645.9 per 100,000 and our current rate is 591.9, which is rated green. This is a really positive result, but the trend shows that there has been a gradual increase in admissions. Financial pressures are mounting and we're seeing more self-funders, deferred payments and admissions following community hospital discharges. We're investing in Pathway 1 provision and reviewing the wraparound service, which has shown promising outcomes. CHC transitions remain a challenge and we're increasing social care staffing to address this. But we are on target, but the rise in acuity and financial strain mean we must remain vigilant and proactive on this particular case. Key performance indicator 3 is outcomes of short-term services for reablement. So our target here is 84.0% of people requiring no ongoing care after reablement. We're currently at 82.8%, so we're rated amber. Performance dipped slightly during winter but remains above the national and comparator averages. The expansion of Pathway 1 has helped more people return home post-hospital through early discharges, which may impact long-term outcomes. But despite system pressures, our reablement outcomes reflect strong service delivery and commitment to independence. Key performance indicator 4 is people aged 65 plus at home after rehabilitation. So this indicator is not yet updated for Q1. You'll see that in the report. This is due to national changes in reporting methodology. The last available data from March 2025 shows that it was 81.3%, so rated amber, just below our target of 83.0. The business intelligence team, my team, is working to incorporate the new methodology and we expect updated figures shortly, so I'll be able to share those with you all. We anticipate improved clarity and accuracy in future reporting, and early signs suggest that this is a continued strong performance. And then number 5 is annual care package reviews that have been completed. So this is our most challenging area. The target is 95%, which is quite a stretching target, and our current performance is 74.9%. So it's rated red. We acknowledge this shortfall. Workforce pressures and rising demand have made reviews difficult to prioritise. However, we are exploring self-review models and AI-assisted solutions to improve the coverage. Importantly, regionally, we are still performing really well in this area against our comparators, and our principal social worker is actively seeking potential self-review models as well to support. We are not where we want to be, but we are looking at smarter, scalable solutions to meet statutory obligations where we can. So in summary, while we face notable challenges, particularly in managing admissions for younger adults and ensuring timely completed of annual reviews, we are demonstrating strong performance in key areas. Our admissions for older adults remain within target, reflecting effective investment in community-based alternatives. Reablement outcomes continue to exceed national benchmarks, showcasing our commitment to promoting independence. However, the pressures are rising, acuity workforce constraints and increasing demand require ongoing attention and strategic planning. We remain focused on maintaining high standards of care and ensure that our services adapt to meet the evolving needs of Worcestershire residents. Just to make you all aware that from Q2 we will be reporting through our Power BI service dashboard in future, which will link in with the same as the other reports that you get through Scrutiny. For some reason the adults reports seems to have stayed this way for a while, so since I've taken over we're now going to move to the Power BI dashboard, so you'll receive that, so it'll look slightly different next time.
Okay, thank you. I think we have a few questions. I think Councillor Cross.
Thank you, Chair. Yeah, thank you. I mean, also lots to get our teeth into as well on this. I'm keen to understand, please, our high cost placements. So how many individuals are counting, for how many individuals is there over £1 million of spend? And how are we working to reduce our reliance on external high cost placements, please?
Kerry, Mark, did you want to come in about the high cost placements?
Can I just, for clarity, when you say over £1 million, do you mean per person's cost? I'm not aware, I wouldn't know, but I'm certainly not aware of costs associated with more than £1 million per person. We certainly had one individual transitioning through from Children's Services, not probably 12 months or so ago, with significant costs, but actually that person's costs are now with the local ICB, not with the local authority. So in terms of then high cost packages, perhaps we could give some information. So we're in the middle actually of looking at a report that our finance colleagues have brought us, and actually we are focusing on costs above, currently reviewing £4,000 per week, so approximately £200,000 per placement per year, to have a look at those, and we're going to link that in with the work around continuing healthcare when we have the new staff in post, to see whether we've got enough evidence to trigger new checklists to reconsider whether there are any associated health costs with those individuals that we could discuss healthcare funding for in the first instance, but also to have a look at whether, since those individuals have been placed within those services, whether there's any better value options available locally now, particularly if they are out of county. So work is underway. I mean, every month we work with our finance colleagues and our commissioners around kind of high-cost packages, some which we will commission in emergency situations that are short-term costs. We've got commissioning panels in place, so anything actually over £750 for our area team panels and £1,500 for our mental health and learning disability cohort go through a commissioning conversation and panel which will have representatives from commissioning and operational senior managers, and we speak directly with the social workers and the social work team managers to understand what the provision is costing, why that's needed, and whether we've exhausted all alternatives. So I can't give you specific numbers around that right now, but we do look into those quite regularly given the current financial position.
Thank you. I was just going to provide you with some information on our most expensive client that we have at the minute. That's £12,800 per week, and they do attribute Section 117 funding. So annually, that person costs around £665,000 gross, which is around £400,000-ish to us.
Thank you for clarifying.
Thanks, Chair. And just on Councillor Cross, in terms of a general comment, in terms of what we pay for in Worcestershire in that sense, or the rates we pay. I did some work more recently, having conversations about sort of budgets going forwards, and made reference to a report that's called the Use of Resources report that's actually generated for Worcestershire and other local authorities in West Midlands by Local Government Association and ADAS, which is the Association of Directors of Adult Social Services. What that, I've not got the information sat on my desktop right now, but from memory, what that sort of demonstrated that, in fact, for the spend on adults that were in adult social care, were probably slightly less than the average across England. If we looked at the average per what we were spending on every adult in social care, so we were not on a high spender in one way, or by one measure. I guess when we looked at older people, we were significantly less than the England average. So we was paying, in general, we didn't pay as much as the average across England on our older people's spend. So that was much lower, significantly lower. I think what we then looked at is in Worcestershire we spend considerably more per adult on short-term services. And that's exactly what we was talking about before in terms of reablement and the performance that's in here, which is strong around getting people back on the feet and not relying on long-term care. And how that then translated when you looked at spend per adult on long-term care, it was less than the average across England. So just some interesting features there. I would argue that's absolutely in line with our strategy and policy. You know, we want to try and get people back on the feet rather than relying on longer term services. And it does show up in some of those reports that will be, that are available to us from, as I say, Local Government Association and ADAS.
Thank you. I think about this area, is it on section 4, Councillor Hardman? Did you have a question about people at home following rehab?
Yeah, I mean, as you know, I'm very keen on reablement. And I was slightly concerned that we've seen over the years, in effect, a 5% reduction in our target. Now, I suspect that is a really complex thing to explain to me as to why, but my instinct would be that because of the pressure on the acute, they are discharging people who are probably not well enough, and then they're coming back into the system. I don't know whether the Director or Kerry have got any thoughts or comments, but it's not a track that, you know, we were doing so well, I felt.
Thanks, Councillor Hardman. Yeah, I mean, it is an area that we've been very, as just mentioned, really, very proud of in terms of our performance over time, really, in that sense. I think the report, though, in terms of that particular KPI does still suggest that we're still strong when in comparison to others perhaps in the region or maybe more nationally. I think one of the things that would, I think you're quite right in terms of hospital discharge. People are now leaving hospital perhaps much sooner than they would have otherwise done in that sense. Although our length of stay in one of our acutes doesn't necessarily support that in terms of reduced length of stay, but certainly probably coming out of that system with higher level of needs than before. And I think on that, just generally speaking, we're seeing right across the piece an increase in complexity. And so, you know, we probably now working with people, quite rightly, to try and still get them back to a greater degree of independence. But the more dependent you are, the more challenging that becomes in terms of the numbers, I suppose. So that would be one other reflection, Councillor Hardman, that would be my sense of why we're probably not quite where we were more recently.
It's really difficult, but then I don't quite understand where the complexity has come from for, you know, over 5 years. Does that mean that, I can't quite work that out, to be honest.
At the risk of going down the sort of route of, you know, the pandemic as it was and COVID-19, I think generally speaking, we've just looked at the reports that we had moments ago, and I know again there was a number of reasons perhaps why that, but look at the increase in mental health needs that there now are, if you like, in that sense, whether there is a direct correlation with the pandemic, and then, you know, as we've come out of that, the needs that would have been around and apparent during the pandemic probably have been maybe suppressed somewhat, and we might now be seeing that come through, because obviously, you know, particularly for older people, they may well have been, you know, having an increased level of need because of the inactivity perhaps was around during the pandemic and COVID. That was one, again, rationale that's been given to that complexity.
Just on that note as well, I think delays in operations and things as well have certainly impacted some individuals, and there's been significant decline. But just back to the indicator, I just wanted to add, in terms of people remaining home 91 days later, there will also have been a slight change in terms of our absolute drive to people going home from hospital, so that they do not go into hospital and never make it home. And quite often we are supporting people, as we've said, with more complex needs that perhaps might have just gone straight into long-term care. So we've got the wraparound service, and we've got really good outcomes where then some people will still be at home 91 days later. But for some people, they've had an experience of rehab at home. But the reality is, you know, within that period, that the evidence shows us, quite often using technology to understand what their level of need is, that they do still need to go into long-term care. And therefore, whilst there has been a slight drop in that, we would rather people go home first. Hence, you know, we have our home first service, even if that means within that period of time they do need to move on to alternative arrangements, or, you know, what we want to avoid is a readmission to hospital, and then at that point we will probably make decisions about their onward destination. But actually for some people, you know, going home, you know, they might otherwise have just gone straight into care in the way we used to work.
Thank you. And I think, can I just change tack slightly and move to the budget? That's okay. Obviously, I think we were looking at sort of 3 million, closer to 4 last time, but we're now looking at closer to 8 million forecast overspend, and the key areas are older people and more so learning disabilities. I'm just wondering, that's changed quite a lot since the last forecast. Is there a particular driver of that, or maybe the forecasting wasn't quite to track, and how will we manage it with the winter ahead? Sorry, Richard, I've kind of jumped over from performance monitoring to budget. Did we want to jump back a step and you could talk about the budget? No,
I don't mind. I'm happy to present the budget paper and talk about that. I'm happy to answer your question now, however members feel.
I think we're happy to move on to the budget paper. Sorry, I've just squashed them both together. But yeah, perhaps if you could give us an outline and then you could answer my question, any further ones, that'd be great. Okay. Thank you.
Fabulous. So within my presentation, I'll be focusing on two parts. We'll have the overall corporate position of the monitoring, and then I'll give you some information on the adult-specific information later on. So Q1 this financial year, we are forecasting a break-even position, but that is after utilising 11.6 million in reserves and the 33.6 million of exceptional financial support. We are seeing significant financial challenge. As we know, the cash which we can generate as an organisation is limited, and we are seeing expenditure increase above that threshold. We're seeing overspends within social care areas, so adult social care and children's social care, similar to what we did see last financial year. However, this year in Q1, we are seeing underspends within other areas of the organisation which aren't particularly demand-driven. And just to mention that directors are looking at mitigating the in-year overspends that we're seeing in some service areas. So to put a visual representation on where we are financially, on page 58 of your packs, you can see the variance column says 0, but if we look down the service area columns, we see a 7.9, just shy of £8 million overspend in adults, and a £4.3 million overspend in children's, and then a number of underspends within other particular areas. We do have a savings programme for this financial year. It totals £12.5 million. 82% of those savings have been achieved in year, which is positive news. There is still some way to go to turn some of the amber savings into green. We do have one red saving at the minute, 310 in children's. I would just like to point out to members of the panel that the 230,000 that sits within adults at the minute showing as amber at period 3 is now green as we sit now. So adults have achieved the full savings targets of £674,000. If I touch on reserves, we started the year at £93.7 million as our total reserve balance. The majority of our reserves are earmarked, so they're not for us to use to offset in-year pressures. So if I can draw your attention to the line which says the risk reserve, that's the reserve which we can utilise to offset pressure. We started the year at 28.7. We're forecasting at the end of 26 that's going to deteriorate to 30 or just over £13 million. So there is quite a reduction in that element of the reserve. And we're forecasting £70.7 million as a reserve balance at the end of the year. The next slide in your packs is around risk to the local authority and the dedicated schools grant. So at the end of 25-26, we're forecasting an overspend of over £86 million within that particular area. We've seen increases in the numbers of EHCPs and demand over the last 12 months. By the end of end of March 26, that forecast overspend is estimated to increase to £184.4 million. At the minute, we do have a statutory instrument which allows us to carry that debt forward on our balance sheet. That's been extended until March 2028. We are cautiously waiting the white paper to, I guess, see what that says in the next few months. That's going to detail a potential size of the risk, which again may hit the local authority. The capital programme currently sits at £495 million. In year, it's £177 million. And at the end of Q1, we spent £24 million against that £177 million budget. The majority of the programme is funded by external sources, so we'll have grants in Section 106 income, so that's 56% of the total programme, and we are borrowing money equating to 41% of the programme. So when we borrow money, that incurs revenue costs to the organisation. The table on page 63 details per area your budget and your spend. So within this panel, we're looking at some elements within the health and wellbeing line, so smaller than a number of other areas that we have within the organisation. The next slide details some information around potential reductions in the capital programme given the organisation's financial position. So we are looking at reducing the borrowing on a number of capital schemes. We'll see in the slide there's information on Redditch Railway Station, that's around a £12 million reduction in borrowing. There are other railway schemes just shy of 2.6. Hampton Bridge, we're forecasting or putting forward to not use £6 million of borrowing. What we were able to do there is swap a grant, so use that rather than use the borrowing costs. And there are other reductions in highways and footways, but just to mention that will be going to full council in November, a recommendation. So if I skip on to the adult services information, and I am looking at the table on page 66 of your packs. So if I look down the forecast variance column on the right hand side of the table, what we will see in the top 4 areas, there are client areas, so where we're seeing our demand. So we're seeing pressures across older people, learning disabilities, physical disabilities and mental health services. We've seen some slight underspends within the commissioning unit and some of the central areas. Again, an overspend within the adult front door. So when we total all those up, that shows our just shy of £8 million overspend on a gross budget of 336 mil and a net budget of just shy of 174 million pounds. I did touch on our client areas causing a lot of the demand. So your next slide, I really want to detail the overall overspend for the directorate is £8 million, but when we look at the care that we provide for the individuals and how much that costs, we're spending £9 million more than the budgeted expectation. So the next bullet points relate solely to what we're spending in the care market rather than relating it to the table above in the previous slide, because I'm showing the net position before and now I'm just talking about placements. So within older people, we're showing an overspend of £3.1 million, and residential and nursing care placements are driving the majority of those areas of overspend. So I guess, Chair, just to touch on your question earlier on what was driving that overspend, we've seen a significant increase in the numbers of people that are entering residential and nursing services in this year compared to last year, which is I guess, driving the overspend last year to this year in that particular area. Within LD, we're showing an overspend of £4 million. So again, client numbers are increasing above the budgeted expectation that we're seeing in those services. We are also seeing increases in costs above the budgeted expectation, again, within residential services, daycare and supported living services. Within physical disabilities, we're showing an overspend of around £800,000, and residential services, again, are driving that area. So we've seen an increase in cost of 11.4% above the budget expectation. And mental health, as we had the paper earlier, we are seeing increases in demand in those services. So the numbers of individuals coming through are driving an area of overspend there. If I bring your attention to page 68 and the numbers of placements that we're seeing, again, appreciate it might be incredibly small if you've got printed packs, but if we look at April to June activity compared to what we saw last year, there's quite a significant uptick in the numbers of individuals. So we've seen over 100 people enter services in the first 3 months of the year. We budgeted for a 2% increase over the whole financial year, which equates to around 200 individuals. So we've already seen 1% growth in the first quarter of this financial year in the individuals we're supporting. The next table details cost, which we're seeing. So as we would expect, it is increasing annually, but we have seen upticks again in April time, which, again, if we look back at previous trends, we kind of see that every year. The next few slides I've put in the pack around an additional question that was asked last scrutiny panel on additional information on the budget and how that was broken down and the income sources that we see. So I guess I just wanted to point out a few of the key areas and potentially demonstrate them in a different way than I have previously. We spend just over 39.3 million pounds on employees within the Directorate, which is, I'm going to use my memory here, around 845 FTEs, I believe, at the top of my head. I'm not proposing to touch on premises and transport costs because I guess they are what they say on the tin. But supplies and services budgets and income budgets we'll go into in a bit more detail because those are some of the larger numbers that we're seeing. So out of the third-party payment line of £288 million, £277 million of that is spent on care in the market. We spend £3.1 million with the Health and Care Trust, providing staff for our equipment service and occupational therapists relating to reablement. And we have the Disabled Facilities Grant, which is £7.6 million, which we passport to districts. So those three elements form that £288 million. And we have £164.5 million worth of income, which I've detailed in further slides. So I'm just going to go to slide 71. Out of that 164.5 million, 90 million pound of that is government grants that we receive, and 73.4 million pound is income we'll receive from either the NHS and our customers, which will contribute towards their care. And we do receive some money from public health for services that we fund which meet public health outcome framework criteria. So that's just shy of 900,000, excuse me. If I touch on some of the grants which we receive, as a directorate, we have the Better Care Fund of 19.2 million. We have a proportion of the social care grant, because the social care grant covers both adult services and children's services. That's 27.9 million. We have the Market Sustainability and Improvement, often called MSIF, if you've ever heard that term anywhere before. That's 10.4 million. The Local Authority Better Care Grant is new this year. What we have done is rolled forward the Improved Better Care Fund and the Discharge Grant, which we received in previous years, which totals 24.5 million. The DFG, Disabled Facilities Grant, which I mentioned, and we receive a few others, which I've just totaled around 175,000. And then my last slide is just around client income that we receive. So just to give members of the panel some information on that. When we look at our long-term residents, we receive just shy of £34 million worth of income for those individuals. For the NHS, we receive 23.4 million. Now that covers Section 117 and CHC, so those two I've combined. I am looking at splitting those out, given the conversations that we are having, so I will do that later. And fairer charging is income from our domiciliary care services and short-term services. That's just shy of £16 million. So in total, yeah, out of the overall income that we get, a large proportion is grant funded and income which we receive from clients. So happy to take any questions anyone may have.
Did you have a question?
I did, and then you just answered it. Oh, so I was just trying to see where the £2.2 million reduced forecast income from ICB, CHC income, where that would have gone, and the answer is the table on page 73. So thank you very much for giving that answer during the whole process. I'm interested to understand on page 66 what's happened with adult front door, where we've got a 400,000 variance compared to budget, please.
So that's predominantly driven by staffing within that area. Sorry, I'll turn that area. So our adult front door obviously is our area to try and mitigate that demand. There's been some investment within that particular area to get more staff to, I don't want to say man the phones or deal with members of the public. When we set the budget, there was an assumption that there would be an additional income stream for that particular area, which didn't materialise at period 3, but has materialised at P6. So when we look at the next set of information, that £400,000 will reduce.
Thank you.
Councillor Hume, thank you.
Thank you, Chair. Regarding the 3.1 million OT therapist equipment costs, I'm looking at page 70. It's perhaps small beans, but in the interest of minimising waste wherever we could, is there any sort of processes in place for the return of items that are no longer required, where they can be reused, things like, you know, the metal frame walkers? You know, is there a sort of way of monitoring where they are and how they get returned and reused where necessary? Please.
Yeah. Or do you want to go?
We're looking at each other to who's going to answer. The answer is yes, there is a process in place and it is managed by the service that delivers the community equipment service, which is within the Health and Care Trust.
Could you just expand a little bit on how that's conducted? You know, because I'm aware of walkers in people's garages that are no longer being used and have been there for months. So what is the process for you know,
so
they will
know where they have distributed that equipment. They may sometimes when equipment goes out, there is a note that actually says, when you are done with it, please can you let us know. So to a certain extent it can be reliant upon the person who has received the equipment, rather than employing somebody to constantly ring up and as good as Harris folk to see if they have finished with their piece of equipment. If it is something that is delivered and is guided by one of the visiting teams, so for example, if it is someone who's received equipment that is part of their recovery, then it will often be noted then when it is ready. But there is a process in place, but it can sometimes also depend on the person actually just picking up the phone and saying, you can collect it now.
So if I can just, I guess, provide some additional assurance on the recycling and reissue of equipment. We do meet monthly to discuss the financial position of the equipment service. There are stats on recollection and reissue and decontamination of equipment items. I was thinking, oh, can I get it up before I answer this question to give you the exact information? But they are significant reutilisation rates. And within the information which I can provide, it would detail, if we were to buy all these items new, what would that have cost? So kind of give you a bit of an annual saving. And we're in the millions when we're looking at that. So if we find it useful, I'm happy to share that, I guess, with Health and Care Trust authorisation.
Thanks, Chair. It was really maybe to come back to your original question as well, in terms of what we see as being the issues of driving the sort of costs and projected overspend at this point in time. I suppose there are a number of things, aren't they? We had a conversation earlier within the committee about continuing healthcare, and I'm not pointing there to say, but there will invariably be impact on council budget as sometimes where those people come off continuing healthcare and then we have to fund their care. There's obviously a contribution towards it then, but it would still be a potentially significant costs. I think we've also got an area of work where people in residential care, say, for example, and have been paying for their care themselves, and then their assets and money they have available falls below the threshold, which Councillor Hardman referred to before, that 23,250. And we have to pick those cases up and then provide local authority funding. So those are sorts of areas of work that we can't always anticipate the numbers that will be coming forward in that way, because we don't know if you're paying for your care yourself, that we've got that awareness. I suppose then, just to go on to the budget setting bit, I think Richard's already alluded. So in terms of setting the budget for this year, we set it on the basis of holding the increase in numbers to 2%, but it does look as though already we're far outstripping that in terms of the numbers. And I suppose what I would also say as well, in setting the budget for this year, we weren't in a position to actually recognise fully the impact of the increase in national insurance on employers, providers in the market. I think we probably received funding that would maybe enable us to fund half of that impact. But we didn't have any funding from central government and couldn't make that full commitment to supporting those providers with the increased national insurance payments. And that was alongside any percentage increase we would have negotiated in setting fees for this year, and also impact of national minimum wage on those providers. So, you know, there are a number of things that feed then the impact on the budget and the projected overspend that, you know, maybe we could have anticipated to some extent, but we wouldn't have received the funding fully for some of those things anyhow.
Thank you. And I think Councillor Hardman.
We're sort of going on to the main part of the budget. I mean, I had 3 points on this, if I may, Chairman. I mean, one, the overspend in learning disabilities, this due to increased numbers. I have to say this seems to happen year after year. Do we not know how many children are transferring across, or am I misunderstanding the problem and they're moving in from Dudley or somewhere else? Because it does seem, I mean, if I look at the overspend, I mean, it is that has in effect doubled it. And that was a sort of failure of either well, children's or other partners not telling us that they were coming our way. My second point would be, if I look at the figures, I don't think we're quite stating the true position, because where we've taken a charge on the house, if I read this correctly, it doesn't actually bubble up until we've taken the money. So, you know, the house is sold by the executor, and so then it comes back into our system. Well, that could be quite a long time, but it strikes me that we're slightly artificially overstating the problem, because tucked away over here, we have sort of 12 million quid's worth of revenue coming back. I can tell the director's about to disagree with me. And the last was, of course, there's been quite a lot of chuntering about the capital programme. I have absolutely no idea what the £3 million cut to either education or to social care is. I mean, there were some projects I was quite keen to see driving forward. So I suspect at some juncture, Chairman, where either, I mean, I don't suspect people can tell us like that, but I do think it might be something we would want to have a look at.
So I think, thanks, Councillor Hardman. I'll try and recall the points that you made. I think Kerry's going to come in relation to the anticipation of numbers coming through and maybe make some comments on that. I think just in terms of capital programme, we don't really have a significant amount of capital spend in the directorate, and certainly in adults. We have some grants that we've still got that are going to support some of the changes we're looking to make. One notably in mind is around replacement care and some renovations to a new site where we're looking to bring those services all together. But other than that, we don't tend to have a significant capital programme in the directorate.
No, I mean, alluded to exactly what I'm bothered about, to be honest, which is the old children's centre that we were going to convert into a centre for the people of Pershore, my constituent, and various others. And, you know, I'm worried that what we're going to do is we're going to circle the airfield yet again, and Pershore won't be closed because we won't inject the capital into it. But if we've got a government grant, presumably that's ring-fenced and can't be torn up.
Thanks, Councillor Hardman. And I know Richard would probably give you the exact name of the grants, but the position that I'm in at the moment is those changes will still be going ahead, and we'll be able to do what we've previously reported on in terms of where that replacement care will be provided.
Okay, so oh, sorry, I was going to come in on the grant. Is that okay? Yeah, it's a community capacity grant. Totals just under £1 million, which we have in the programme. So that's funding that we have.
Okay. Well, we'll see if your optimism.
Just to come in on the points then about the cohort that are increasing spend in learning disabilities. It's really important that whilst we kind of bunch this spend against learning disabilities, it's actually inclusive of people with neurodiverse needs, autism, etc. It all sits under that budget. And that portfolio sits with Francesca, who was with us earlier, and we absolutely have seen a huge increase in terms of the numbers of people requiring assessment and possibly funded support via the council with neurodiverse conditions in the last couple of years. When we started the adult neurodiversity team known as ANT, we had about 100 people. They were previously known to us as kind of a term I'd prefer not to use, which was vulnerable adults. And they didn't kind of people with a set of needs that didn't fit into any of the other generic service areas that we have. And so that team started with about 100 people to transfer across, and within the sort of last 18 months, and we will bring a paper at some point, that team have worked with about 400 people. So it's not just people with a complex and severe learning disability that's under the Learning Disability North and South teams. It's also people with neurodiverse conditions. So we have a really good grip and relationship with Children's Services, knowing the young people that are coming through. We often know about them from sort of 14 to 16 now, and we can do that forward planning work. They're doing the preparation for adulthood. They're talking to us about what the likely need is going to be as they come into adulthood and what services we might need to start thinking about commissioning for them at a much earlier stage. So we certainly don't often have young people now that we don't know about and expecting to service, but the spending against that budget is much broader than children coming through from Children's Services. Also, what we often see now is that we're looking at the difference in costs as well between supported living and residential. And I think, you know, particularly in older people's services, but also within the learning disability cohort, it's actually quite often now of a better value to be looking at some of the residential options than some of the higher cost supported living. In the learning disability and autism cohort, we absolutely have seen a number of very high cost placements coming through to the council that were continuing healthcare funded. And some of those had been healthcare funded for 8 to 10 years, and they've had reviews and they're no longer eligible. So that has caused some of that pressure. And like I said earlier, when we were talking about continuing healthcare, we don't know about these people till we know about them. So very difficult forecasting wise. Just to cover the older people spend and that increase in long-term and residential. We've done a deep dive into all of the new admissions, but and there isn't anything, there are very small numbers that we actually move people from their own homes in the community into residential and nursing care. The majority is through hospital discharge or recent hospital discharge, community hospitals. They're already in care with requesting a deferred payment or they're self-funding pickups. So that's a significant number. But reassuringly, and Rich, correct me if I get these the wrong way round, residential, the average time span in residential care for older people is 1.6 years, and then nursing is 1.4. So it used to be 2 years. So I suppose what I'm trying to say is that, we're not admitting people to residential and nursing care early, and they're spending significant periods of their lives in care. They may have been in care longer than that if they've self-funded for a period of time, but the average for the council, once we're funding someone, is actually quite low. And obviously every month we will have a number of leavers and a number of new starters, and that, dependent on what that looks like, it will impact the overall spend. But we've deep dived into all the new admissions, and certainly, we haven't seen anything that would suggest that we're placing people that don't absolutely need those services to keep them safe and well, and in many circumstances, alive and well with the complex healthcare needs they'll have when they go into nursing care.
Thank you.
And Councillor Hardman, sorry, I neglected to make reference to your point around the deferred payment agreements. And I think with ongoing conversations really as to whether we can model the financial impact of that, perhaps, if I can be as bold to say, better than perhaps we currently do, to see whether in fact we will regain some of that income, and effectively there'll be a nil cost then to the council for those placements where we do have a DPA placed, deferred payment agreement, sorry.
Thank you. And Councillor Cross, your question?
Thank you, Chair. Looking at page 64, I'd be quite grateful for a pointer on the proposed reductions in borrowing for highways and footways of 6 million, or education and social care projects of 3 million. Just where I could find details of these. Obviously, it will come in November, I hear, but where I can look up beforehand, just to get eyes on this and try to understand potential likely impact on residents' lives or amenity. Thank you.
I think, Councillor Cross, with footways and footpaths, etc., that's all the environment panels who need to take that. But I guess the social care one does relate to us, which you can.
I think in the pre-information to the November cabinet meeting is where there will be some more information. I'm not in a position at the minute to provide that level of detail.
Thank you. And Councillor Morris?
Thank you, Chair. So thank you for the papers, but it shows still the ongoing saga of continuing demand-led services just increasing and increasing. However, we benchmark similar or better than a number of other areas. So this is clearly a national issue, not a Worcestershire issue. So my question is really to the director of the services: what can we do? He is well wired in through ADAS and LGA, but what can we collectively do to try and get this government to really speed up the process of review and legislation to either enable more funding or to legislate more effectively to mitigate the issues that we're going to be facing with adult social care and children's services? We can't do this alone. And what's happening whilst all these issues are going on is that we're cutting, and therefore affecting the service levels wider than, with the wider area that we look after, to the residents of Worcestershire. We need to get the message to national government, and we need to get that changed nationally.
Yes, thanks, Councillor Morris. A point well made in the sense that you're quite right. This isn't a Worcestershire, just a Worcestershire issue in that sense. You know, we speak to colleagues across the region and wider than that, and you know, these are all very similar issues that councils, local authorities are facing where they have adult social care responsibilities. In terms of what we can do about it, then we tried to do or push through from a regional perspective into national ADAS to ensure that when they are at the table and hopefully having discussions with national government, that they're fully aware of the pressures that we face. We also, obviously we've got the Casey Commission, where there'll be an initial report from that commission in the early part or at least next year in that sense. But you're quite right, then there is a sense that the full report won't be available until 2028, so there's a further delay in relation to these issues. And we also, we often, certainly as a region, ADAS region that is, we have, for example, the Director General for Adult Social Care, who feeds into the Department of Health and Social Care. And I don't think we would leave her with any doubt what the conversations that need to take place there, particularly around, because what often happens, the focus falls on the NHS and not social care as much. So we try always really to lobby and to get our voice heard through whether that's ADAS or more directly into the Department of Health and Social Care. And we'll take every opportunity to do that.
It's wider than just you as well, Mark, but what can we all do to try and help that situation? Because I accept it's not just officers, it's politically as well.
Can I just add one small comment to what's just been said, in that one of the areas that the government is pursuing and which adult social care is intended to be the main pilot from 2026 will be around fair pay agreements. There is currently no understanding as to how this will be funded, but of course it will set a huge expectation in provider markets nationally in terms of what we should be paying. I think whilst most of us would in this group, in this room would agree that actually fair pay for those people that are delivering care is an essential part of maintaining that workforce and those skills. There is no understanding yet as to how this will be funding, but if it is implemented from April next year, it will be implemented based on a consultation which has yet to begin this autumn, and of course which will be determined after such time as our annual or hopefully multi-year settlements are agreed. So that consultation will be opening, and that will also provide an opportunity for every single one of us to respond to it on that, to at least drive some kind of response back in terms of how some of these initiatives will be funded and how they will implicate or how they will affect all of our services and our delivery.
Yeah, and it's always good to hear of initiatives, but I'm sceptical as ever to the outcomes and the payments or the funding that goes with it. But my wider message is cutting capital programmes, cutting services that the county offers affects the whole of Worcestershire population, and this is a national issue that needs to get resolved.
I think Councillor Morris is, yeah, and I think it falls to the wider political remit as well, and there's something we can all do to lobby cross-party with this. Yeah, thank you. Okay, do we have any more questions? Comments, Councillor Hardman?
Quick one. Of course, Shared Lives has been a great success. And the Cabinet Member for Children's, I noticed today, is making some reasonably heroic statements over funding the fostering service in a new and different way. I think it's something that we ought to consider as to whether, if the rates of pay, in effect, are going to be dramatically jacked up. I mean, I personally don't think that this will work in a month of Sundays. We looked at it several times. But I'm worried that it'll have a ripple-on effect into shared lives.
Councillor Hardman, it's something that we need to be aware of and look at, don't we, in that sense of stuff. So I'll take away and have a look at what our current payment method and model is in terms of shared lives, and whether there's any focus that we need to give to that area of service, given the, as you say, the impact that might be coming from changes in children's services.
Okay, thank you. Do we have any further questions, comments? No? Okay, thank you. So we can move on to the work programme and let some of you go, I guess. Thank you very much. Right, so looking at the work programme for December, we've got a real focus on safeguarding, and these are all scheduled in there. We've got the Safeguarding Adults Board annual update, and we've also got delivery of the adult safeguarding model. I would also be anticipating the next quarter of results, the budget and the performance results. And I think with those, looking ahead to the next meeting, that's a good full schedule and where we really can focus on safeguarding. But I'd welcome any comments on that or the work programme in general.
Just two things. One, I would like us to have the ICB here to question about continuing healthcare. If Kerry can facilitate that, that would be great. I don't know whether it's a joint panel with the health and wellbeing, adult social care and the health and wellbeing looking at it. But we do think I think we do need to scrutinise the ICB and their contributions to CHC. The other one is I would like a session. I can't see one on the forward plan with partners and community. The county has many partners supporting adult social care, and I think it would be good to have a kind of partners session where we look at their contributions and support, and if there's anything more that could be leveraged from the community in that aspect.
Thank you, Councillor Morris. Yeah, so if we add that to the programme, everyone content? That makes sense. Yeah. And
Chair, there was just some concern in terms of the date for the safeguarding work, and that might be coming a little sooner than we'll be able to sort of deliver on some of that. So maybe if we could offline, maybe just have a look at whether we can swap one or two things around. Would that be acceptable?
yes, thank you. And I think, do we have anything further anyone would like to see added? Councillor Hardman.
I didn't want to, and I don't know whether the director's got any updates on CQC inspection, because they must be coming soon, I would say, and I didn't want to, I mean, I can't remember whether we've got it on the forward plan now.
Did you want? I can certainly, obviously, just give an update. I mean, there should be some comms that will have gone out, and I know that I've just seen flash up on my screen an all-member briefing that I've asked to be put in, so I can update all members across the council. But just to give you some key dates, the CQC inspection, on-site inspection, will now take place week commencing the 10th of November. We're not exactly sure which days, but we will block out the full week to make sure that we're available for them when they come on site. If I then work backwards, we're asked to give a leadership presentation to CQC. That will be online, and that is now scheduled for the 15th of October. And the following day on the 16th, we'll be speaking to CQC about the logistics of their site visit, etc. So yes, that's exactly where we are. We know when they're going to arrive now. We know when we're going to give the presentation to them. They've required us to still provide some information back. Today was a deadline day for the cases that they wanted presented, 50 individual cases, anonymised obviously at this point in time, but they will choose 10 out of that 50, and we will then make contact with the residents and ask whether they would be willing to be part of the CQC inspection. So they're just a flavour really of things to come, and we now have fixed dates for, as I say, the presentation and the on-site visit.
Thank you. So I guess if we could just receive an initial summary at the December meeting of the events.
Yes, well,
as far as April, I appreciate.
Yeah, no, sure. I think
just
certainly in a sense that they've asked for my availability from the 24th of November for initial feedback, but often they ask for that not to be made more public until the report is written. We've had an opportunity then to actually comment for factual accuracy on the report, and then once it's gone through their governance processes, CQC's governance processes, that's when we would have the final report given to us and more formally, and then it would be in the public domain.
Thank you. So then I guess it's more of a nuts and bolts, a bit similar to now where we are. We're after, not the, yeah. Okay, thank you.
I think what they'll certainly want to do is there'll be an interview with CMR with Councillor Eacock. That's a definite. That's one of the one of the feedbacks that we've had to give is that they've listed a number of people that want to speak with, and we've had to go back with their availability for either the week before the site visit or on the week of the site visit. Again, Councillor Olcott, your name was down on that list as chair of adult scrutiny. So there's a number of folk that we've had to provide availability for, but more generally, although I've arranged for the leader to be involved with CMR, with Councillor Eacock in a conversation about what to expect from an ex-director that is currently supporting the region on this work, they have not formally asked for the leader's availability for an individual interview.
Thank you. So I think, have we anything further to add to the work programme or CQC? Oh, okay. Okay, so next meeting, 4th of December, and it's actually at Wyre Forest. And you weren't here before, and I have promised. Thank you, everyone, for your work and your time. Thank you.